From the American College of Surgeons' 57th Annual Clinical Congress in Atlantic City, this is Audio Digest Surgery, Volume 18, Number 21, with a swift and exclusive initial report from this largest and most distinguished surgical meeting held anywhere in the world. Joining hundreds of other surgeons as they rapidly fill the convention hall ballroom to capacity, we'll sit in on one of the meeting's most popular panel discussions, a five-man confab on Crohn's disease. Our panel moderator, the Cleveland Clinic's Rupert B. Turnbull, is now ready to begin. Let's listen.
The theme of this panel in Crohn's disease is the do's and don'ts of Crohn's disease, if you will. We have a panel who are experienced with Crohn's disease in the colon, small bowel, and rectum. We have, first of all, Dr. William Hawk, pathologist. We have Dr. Donald Gallagher, surgeon. We have Dr. Henry Tuman, gastroenterologist. We must include the gastroenterologist in this disease or in any discussion of it. He plays a big part in this surgical disease, and we must know what he thinks, and we have to combine with him every day when we handle these cases. We surgeons are not very good at the medical management of Crohn's disease. And finally, Dr. Richard Marshak, radiologist. We need his help every day in the diagnosis of Crohn's disease. I would like to start first with Dr. Hawk, who will tell us what Crohn's disease is. We want him to take us into the operating room. We call him in to look at it, as you do, you're a pathologist, and we want his opinion as to the disease we are dealing with. Dr. Hawk.
It's rather difficult, I suppose, to talk about a disease, the knowledge of the etiology of which is absolute. We know absolutely nothing about what causes Crohn's disease, and yet I think we have a great many facts which we can present to you, at least, in outlining how to recognize it. Pathologists like to classify diseases, and transmural colitis or Crohn's disease falls in the group of the nonspecific ulcerative colitis. Now, grossly, I think all of you can recognize this disease from the mucosal side up, in which you see the rather characteristic serpiginous ulcers, which segmentally involve the colon, with islands of very normal-appearing mucosa in between. In a slightly different variation, the colon is much more diffusely involved, and the terminal ileum is involved by the disease process. And only with diligence can one find little patches of normal mucosa in between these longitudinal and serpiginous ulcers. Now, these two gross appearances are rather easy to recognize, and they have the following histology. The inflammatory process is clearly transmural. There is very marked lymphadenoid hyperplasia, which occurs in the submucosa and also in the subserosa. The ulcers may be quite wide, as in the serpiginous variety. They may be slit ulcers with fissures at their base in other areas. The mucosa, oftentimes at the margin of ulcers, shows mild dysplastic changes, but as one moves away, assumes a relatively normal character. Granulomas receive a great deal of our attention. This is one of the characteristics of transmural colitis or Crohn's disease. Regrettably, it is absent in about half of the cases, and it probably has to do with the stage at which one is seeing the disease. Well, now it's all well and good to diagnose this disorder from histologic preparations and seeing the disease mucosal side up, but there are some things which can be of help to you in the operating room. And one of them is this curious phenomenon which characterizes Crohn's disease, and that is fat wrapping. An early subtle change is obliteration of the mesenteric bowel angle filling in with fat, and then finally the envelopment of the viscus by fat. One can detect that this is an area of diseased bowel, and you will find on the other side of this active mucosal ulceration. I should like to say at this point that the ulceration in Crohn's disease is a secondary phenomenon and not primary. Another curious form, and a little later perhaps, fat extended along the tinea. It appears to have skipped coming up around the mesentery and has appeared perhaps by a metaplastic process. Again, this is an indication that there is something going on inside this segment of bowel. More advanced stage, the fat comes along the vessels as they come up around the gut, and clearly this segment likewise is involved. Now, one other thing which is very useful in the operating room recognition of the presence of lymph nodes in the mesentery. The area of gut which is involved, these nodes, will be enlarged. Often they are like signals, and they will let you know the extent of disease and possibly how far to resect. And this is rather striking. And if one palpates the mesentery to the extent of the lymph nodes, you can get a pretty good guide as to how far the disease process extends by simply going from that signal lymph node out to the gut. And often there will be no disease process in that area. In mucosal colitis or chronic ulcerative colitis, there is no serositis, there is no fat wrapping present to indicate the extent of disease, and in sharp contradistinction to the changes which one observes in Crohn's disease. Thank you very much.
Well, then, Dr. Hawk, you're saying that this disease is grossly and histologically the same in the large and small intestine.
Yes.
I think we have to have that understanding right now in order to go ahead with what our panelists are going to say. It's one disease, then, no matter where it is, from stomach to anus.
It is the same disease process, fundamentally, whether it involves stomach, small intestine, colon, or anus.
Dr. Marshak, would you tell us about some of the radiologic problems and diagnostic problems, and let us have some of your experience?
Now, I have chosen for you today certain principles. Now, these I have gained over the years. They are my own. And this is for you either to accept or to reject according to your experience. Now, I do not believe in acute ileitis as related to regional enteritis. Because of this, I have never been able to use the classification of acute, subacute, and chronic disease. However, since stenosis is almost an invariable end of the process of this disease, I have divided this disease into the non-stenotic forms and the stenotic forms of this particular entity. A dictum is that we do not see extension of this disease in the small intestine. I have, however, seen on occasion extension of the disease from the small bowel into the colon, and I have seen some extension of the disease in the colon. But in the small intestine, it is extremely rare. What happens is that the loop becomes more stenotic, but it stays in the same place. If it's 2 feet in 1948, it'll be 2 feet in 1968. And if you don't operate on a patient, you can follow it from the non-stenotic stage to the stenotic stage. And this happens, and they don't reach the surgeons because he was fortunate enough not to develop sinus tracts and fistulae. When they develop sinus tracts and fistulae, 80% of our patients ultimately reach the surgeons. Healing rarely occurs by itself. Another dictum that we believe in is that whenever you get a recurrence, and many of these patients do, it's always at the anastomosis. I've only seen one patient in thousands of patients who've had recurrences where the recurrence was not at the anastomosis. And the recurrence can either be on the ileal side, colonic side, or both, but it is always at the anastomosis. It practically never occurs proximal or distal to the anastomosis. And if you do this with an end-to-side anastomosis, a blind loop may develop, and these patients can bleed, they can perforate, and I have seen several cases which formed a volvulus secondary to the blind loop. The string sign is not an indication that we have fibrosis. Very many people think that the string sign means fibrosis. Actually, the narrowing that you see in the stenotic segments look more like a pipe stem. The string sign that you see is due to the fact that there is marked ulceration. Because of the marked ulceration, the lumen of the bowel cannot tolerate the barium, and the barium quickly goes from the terminal ileum into the colon. If this was fibrotic, this would be tremendously dilated. The fact that this is not dilated indicates that this is marked ulceration and very active disease. Why is this important? It's important because we know then that this is hot disease. The patient has no sinus tracts, no fistulae. This patient should be treated medically for a while. The surgeon will eventually get him, but this would be the wrong time to operate. And there is only temporary obstruction and not real obstruction with the string sign. Now, sometimes in the sigmoid, you will see a defect in a young person called a carcinoma, no diverticular, and one must remember, and surgeons know this better than the internists, unfortunately, the ileum, which is disease, lies on the sigmoid. You get a pericolic inflammation. This pericolic inflammation produces an area of spasm which can mimic a carcinoma of the colon. And patients have been operated on for this type of lesion when the real lesion is in the small intestine. When one sees in a young person this type of defect, one should always do a small bowel. In differential diagnosis, the most common mistake that I see is a carcinoma of the cecum, which involves the terminal ileum, causing narrowing rigidity. This narrowing rigidity causes one to make a mistaken diagnosis of regional enteritis. We had one recently in a 23-year-old female, which was called regional enteritis. It was extension of a carcinoma of the cecum into the terminal ileum. This is one of the most important differentials that you should make. Another differential is when the entire small intestine is involved, and this is usually called by the radiologist lymphosarcoma or Hodgkin's disease, or sometimes now intestinal lymphangiectasia, which is the same disease as protein-losing enteropathy. But when you see the patient walks in, you should make the diagnosis. I don't even have to look at the x-ray. The patient will tell me, I'm 16 years of age, and he looks like he's 11 years of age. And I know that this is not lymphosarcoma. This is a diffusely ulcerated bowel. The entire bowel is diffusely ulcerated. You can't possibly treat this patient surgically because of the diffuse ulceration. At this time, it was because of patients like this that, like in Whipple's disease, I suggested that you give antibiotics for a whole year. Any drug can sometimes work in granulomatous or Crohn's disease, whether it's steroids, Imuran, or antibiotics. Now, I've never seen complete obstruction in Crohn's disease as a radiologist. Many have told me about complete obstruction, but I don't hesitate to give barium to patients who have complete obstruction. And I remember the first case I ever had. Dr. Crone told me, go ahead, give the patient barium. There is nothing in the small bowel that will make barium hard. Just make sure there's nothing in the colon. And I've been giving large quantities of barium and small bowel lesions ever since, and you don't have to worry. Now, a word about ileostomy. I only see two types of prestomal ileitis. I see the one type that occurs because of ileostomy dysfunction, and this is usually after ulcerative colitis. A colectomy and ulcerative colitis to us is curative. I do not see any other type of ileitis after a colectomy for ulcerative colitis. The bowel proximal dilates because of the ileostomy dysfunction here. It also loses a lot of fluid and tremendous electrolyte imbalance in some patients, and sternal ulcerations occur. This is in contrast to the ileitis, which occurs following removal of the colon for Crohn's disease of the colon. When you remove the colon for Crohn's disease, then the ileitis you get is again Crohn's disease of the small bowel. Now, you can get ileostomy dysfunction, but when you see narrowing and rigidity, this is Crohn's disease of the small bowel. This is in contradistinction to what the group in Boston, headed by Glotzer and a few others, who stated they never saw a recurrence in the small bowel following colectomy for Crohn's disease of the colon. We are now reporting 35 such cases, and I'm sure in comments with the panel that they agree with this statement. As a matter of fact, Dr. Turnbull, some 5 years ago, pointed out that recurrences after Crohn's disease of the colon in the ileum were not infrequent, and we agree with this completely. A stricture in Crohn's disease does not mean a carcinoma as it does in ulcerative colitis. Strictures are common in this disease. Now, in about 15% of the cases, the entire colon is involved, and these cases are the ones that look exactly like ulcerative colitis. It is difficult for us to differentiate the two. We can make the differentiation in about 85% of the cases. I always look at the ileum. If the ileum looks like Crohn's, then the colon is Crohn's. Many people measure the bowel to see if they have toxic dilatation. Don't do that. When you take a film on a patient, on a normal person, there's very little air in the colon. There may be pockets of air. But when air stays in a continuous column in the colon, that means that this patient can't expel the air, and whether this is dilated as much as you like or not, this patient is very sick. This is toxic dilatation of the colon. Whether it's 4 inches, 5 inches, 6 inches, 2 inches, if you see this column of air, this is toxic dilatation, and you better call the surgeon in quickly, because I believe this is a surgical emergency. Not all my medical colleagues agree with this. On the other hand, I have seen them break this kind of bowel. I have seen them do everything. Now, in the past, I disagreed with Dr. Turnbull about whether you see toxic dilatation in Crohn's disease. I agree with him now, but I have not seen the huge dilatation that one sees in ulcerative colitis. But certainly toxic dilatation we just talked about, you see in Crohn's disease of the colon. Thank you very much.
Thank you, Dr. Marshak. Now, we'll go on to the other two members of the panel, and of course we will use our whole panel simultaneously, but with some prepared material ahead of time. Dr. Marshak has said that he doesn't understand or recognize acute Crohn's disease. Well, we surgeons don't know if we know what we're talking about either, but we do encounter masquerading as appendicitis, and all of you do this at intervals. A patient ill for 3 days, 2 or 3 days, age 17, these are actual cases, fever, abdominal pain, leukocytosis, some diarrhea, which you can get with appendicitis, of course, and a palpable mass in the right lower quadrant very often. The patient is taken to the operating room and one encounters inflammatory lesion of the terminal ileum and the cecum. What should we do here? I'm going to ask the panel, should we remove the appendix because we don't know what to do? That's always a favorite operation. Should we go ahead and resect this disease, only 3 days old, or do nothing and call the gastroenterologist? Dr. Gallagher, what is your experience with short-term Crohn's disease?
We don't want to get lost on terms. Here I wouldn't do anything. I think that's obvious. However, other instances where the inflammatory process is acute, it's almost like a vascularitis, it involves the ileum but not the cecum. And in such instances, if the cecal wall is healthy and uninvolved, I would proceed with an appendectomy, but not in the case of the cecum. Obviously, is grossly diseased and fistulization will follow and all the concomitant complications.
Could you tell if the cecum's involved by looking at it very carefully in the operating room?
I think so. If it's completely smooth and the turgor is natural or normal, there's no vascular flare to it, there's no induration, thickening, I believe you can.
Dr. Tuman, what's your experience with this? Will these patients get well if nothing is done?
Well, I would myself prefer not to have any type of resection surgery, and I don't know that I agree entirely about the appendectomy, even if the cecum seemingly looks all right. Perhaps Dr. Gallagher can always distinguish between a healthy and an early disease manifestation in the cecum, but I think there is an element of risk, and I think I would prefer to have the surgeon do nothing except establish the diagnosis that the case is not one of acute appendicitis. Now, as far as the patient's recovering, I don't know that patients with ileitis, at least of the type that you've described here, ever really completely recover. But I think that patients do go into long periods of subsidence, inactivity, and I think that I would at least attempt medical therapy for what it's worth. And I don't know that it always accomplishes all that we want, but I think I would be conservative about a patient like this and treat the patient very conservatively. We've had patients, and this has been particularly true in youngsters, who have gone for long, long periods of time with no apparent spread of the disease, and I think I would ride along and be very, very conservative here.
Dr. Gallagher, what's the fate of such a patient if you close the abdomen and don't do anything? What is the fate? What's the history of this?
Well, again, Roop, I'm talking about the real acute process here, and most of them will go on to spontaneous resolution with or without any therapy, and nothing will be heard from the disease again.
This is the problem of the men in this audience. It's not my problem. Everybody I see, they have holes and leakages and one thing or another, but it's you people that are going to get into these cases and run right into them with a short history. What can we agree on that the patient should do? Dr. Gallagher, say something real quick about this. Take it or leave it. You going to leave it alone or take it out?
I'm still going to be inclined to take it, Roop. Again, if there's gross cecal involvement, I would not.
Okay, can we sum up by saying that perhaps in the average case where you run into such a situation, that perhaps the best thing to do is nothing? Can the panel agree with that?
If you're in doubt, do nothing.
This is not what you're told on other panels. Everyone wants to get the appendix to, that's a favorite operation. We have a saying that you shouldn't cut into this disease unless you intend to remove it. Well, then, can the panel agree then we should do nothing? And we'll go on to the next case.
Well, Dr. Turnbull, I must defend myself about acute regional enteritis and tell the audience that in the 12,000 cases of Crohn's disease of the intestinal tract that I have personally seen, I have never seen a patient with acute regional enteritis. And this patient will not go on to healing this patient will slowly go on to fibrosis, which will take a long, long time and ultimately lead to stenosis. There is no such thing as well as it is rare to get a spontaneous remission in the disease that we call regional enteritis. If you want to say there's acute ileitis unrelated to Crohn's disease, I'm willing to accept this. Now, in favor of Dr. Gallagher's statement is the fact that Dr. Crohn himself believes in acute regional enteritis.
In my defense, I do not believe there's acute regional enteritis either, but I think this is another horse of acute ileitis, and I think it's more on a vascular phenomena than the granulomatous process, lymphadenitis, lymphangitis, and the like. I think we're talking about oranges and apples here. I agree. There's the acute enteritis, as we know it, of granulomatous disease, doesn't spontaneously disappear.
There's one problem here, too, Dr. Turnbull. That is the fact that these patients are not followed by the same doctors over the years, so that the total life history of the disease is really rarely known in individual cases. I'm inclined to feel that this disease may subside clinically for periods of time, but does not disappear and does not subside entirely pathologically.
One investigator in Manchester, England, has followed a modest series of a dozen cases for many years and found out that in that group at least nothing happened in the future. We might say here then that in summary we might not resect short-term disease simulating appendicitis. We might say we could leave the appendix alone if you don't know what else to do. We could consult a gastroenterologist. Remission of the disease often follows, and in some instances there are some reports that report long-term remissions. We are presenting these things to you, general surgeons, so that you will perhaps think about it a little bit and have some way out. We are not positive about anything we're saying. Trends only. I think this is the best we can say. Now, uncomplicated Crohn's disease, 3 years, age 17 years of age, not doing well on medical management. Dr. Tuman, if this is uncomplicated Crohn's disease and the patient is in high school, getting along, so to speak, what about the medical management of this case? What can you do? We're certainly going to ask you to treat the patient.
You're implying that there are no complications in terms of stenosis or fistula formation, abscess, and so forth.
Right.
But the patient is chronically not well. He's 17. You haven't said anything about his growth or his possible retarded growth, possibly I should say. But you're simply saying that this boy has not done well for a period of 3 years. And I assume that he is showing some nutritional changes and that he has run the gamut of the usual medical measures. Probably has had steroids. He probably has had azolfidine. He's been given the benefit of nutritional correction. By implication, therefore, you're saying that these have failed and the patient is continuing to have symptoms, bouts of abdominal pain, diarrhea, of course, febrile episodes, but chiefly suffering from continuing distress.
Yes. Can you hold the surgeons off for a year or 2 or 3?
Well, I think at this point there is a certain, you might say, election as to whether one should operate. There's no immediate indication for operation except the hope that removal of the disease segment is going to give this boy a relief of his symptoms and very possibly, with the disease segment out, enable him to achieve better nutrition, because the disease segment in itself, whatever the metabolic reasons are, can interfere very possibly with some of the absorptive mechanisms and some of his growth mechanisms. I think after a period of 3 years of reasonable trial and the patient's not doing well, I don't think I'd fight too hard to keep the surgeon off, even though there may not be any immediate indication or immediate emergency about this. I think an elective operation with a well-designed operation would probably benefit this boy, and I would certainly not hesitate to consent to surgery for him.
Well, thank you very much, and I think we all have this idea. We do like to have the gastroenterologist treat the patient first, however, and then we operate, and we call the time interval here the respectable interval. If you see such a patient in your office and you offer to operate on him immediately, which probably isn't indicated, you don't have this respectable interval. A patient doesn't understand why a surgeon wants to do something immediately. And sometimes we are absolutely surprised at the response to medical management and the time interval that can be gotten. Dr. Tuman, do you go along with this interval?
Well, I think an interval of trial is justified I think the reason, in my own mind, is that this is to some extent a cyclic disease, that very often the ups and downs, the reactivations are not completely understood, and neither are the periods of subsidence, and patients do spontaneously go into periods of remission. So that I think that unless there is a specific overriding indication for surgery, there's no great reason to hurry. I think we can sometimes ride these out. By the same token, I think we sometimes are inclined to give ourselves credit for benefit that we may not actually be responsible for, in the sense that these patients are going through spontaneous improvements. If we happen to get them at a time when this is the case, why, of course, we'll take credit. But this may not always be so. I think it was possibly Dr. McKittrick many years ago who spoke about the question of colectomy for patients with ulcerative colitis, who said that it would be well to let the patient wait until he has felt the full impact of the disease and experience of the disease before urging surgery. And I think to some extent this can apply here.
All words of wisdom, and I'd like to mark something you said for our audience. You said this disease is known to go into remission. It certainly is, and I think our panelists will agree with this. The disease comes and goes. No one knows why. Dr. Gallagher, this patient has consulted you. The gastroenterologist is through. We'd like to discuss, if you would, bypass procedures versus resection and remove the disease. What would you do here?
Well, first of all, I wouldn't operate on this patient.
Neither would I, and thank you for saying it. Dr. Turnbull talked you into this, Dr. Tooman. This patient has no sinus tracts, no fistulae, no obstruction. I see no reason for operating.
Let me say that Dr. Turnbull has not conned me into this. I would say this, Dr. Marshak, that Dr. Turnbull did describe the patient as being ill and having been ill for 3 years. Now, if that statement is what he's actually describing, I think there are grounds for surgery. These patients, and I've seen a number of them, do not necessarily have to have major complications before one considers surgery. And I can cite enough experience with these individuals who have been in pain and who have suffered nutritionally, who have improved with a resection operation without having reached the point where they had some of the major complications that we all recognize are the specific indications for surgery. You have borderline instances here, as you do in duodenal ulcer. The definition of intractability is one of the hardest things in the world. It all depends on who's suffering with the intractability.
The only thing is, I think we should recall that I believe it was Lord Munyon who said years ago, there's no disease that's going to teach the surgeon greater humility than regional enteritis. Now, if we go in and operate on this young lad who has had no weight loss, who has no complications, he's going to get a recurrence within not less than 2 years, but probably not more than 4 or 5. And what have we accomplished? There are many youngsters with this limited disease form who go in and out of remission to relative exacerbation and do quite well. The ileum is one important organ to general metabolism, and it's not to be taken out lightly. Now, we were going to cure him, fine, but we're not. So leave him alone until a situation occurs where surgery is indicated, but not in a case like this, for my money.
The panel pauses momentarily, long enough for me to signal the end of Side A of this program, Doctor. Side B can be heard by just flipping over the cassette or 2 reels on your tape recorder. Continuing the first of our reports from the American College of Surgeons Clinical Congress in Atlantic City, this is Side B, Audio Digest Surgery, Volume 18, Number 21. Now resuming the discussion of uncomplicated Crohn's disease, panel moderator Rupert B. Turnbull.
If you followed this patient for 15 years, what would the recurrence rate be of a similar group of patients, Dr. Gallagher?
You mean after surgery?
Yes.
Oh, I would say at least 85% of them will have a recurrence.
I think this is very important to know, and this holds the surgeons off. They don't want any recurrences. If you operate in this disease, you're certainly going to get them. So we hold off in this disease as long as possible.
Well, yes, and I think that at the natural history of the disease, not all of us have the ability of Dr. Marshak to interpret the degree of involvement that's going to remain stationary until the surgeon gets in and messes things up. But I would like time to go by to naturally demarcate the borders of the disease, and when I'm at surgery, I can know better what to do. And I think the longer you can hold off on surgery with reason. Now, this is different than in a youngster who's lost weight, who can't participate in athletic events in his formative years, is stunted and everything else. That's another horse.
All right.
May I raise this question? You ask about the incidence of recurrence, and of course, it's recognized that it's very high. Dr. Marshak reminded me of an article in this last issue of Lancet that speaks of 100% recurrence in patients who are followed long enough. But I wonder, and I think this point needs to be discussed, I wonder whether the incidence of radiologic recurrence and recurrence of clinical severity, I wonder how they agree. I wonder what our experience has been in terms of defining the activity of the disease in the lesion that's found to recur at the anastomotic site.
Dr. Marshak, do you correlate radiologic findings of recurrence with the patient's physical status?
Now, I agree that I find recurrence when the patient is relatively asymptomatic. That is true. However, when I find severe recurrences, they're usually symptomatic. So I would agree in part that I pick up a recurrence when the patient is asymptomatic. And also, one must point out that many of the recurrences that the Lancet cited in their articles occurred 10 and 15 years later. So a recurrence doesn't have to recur in 2 years. It can occur in 10 years, and you've given this patient 10 years of good life.
Dr. Gallagher, I'd like to get back to you. Would you prefer to remove this disease, or do you think it could be bypassed temporarily?
Whenever feasible, the disease should be resected. The transection and bypass operation should be reserved for those situations on expiration where you would place the patient's life and death to undertake a resection. The disease, even though it's bypassed, can cause difficulty without question.
You wouldn't bypass it without intent to resect it later.
That's certainly true.
We now have another case of Crohn's disease complicated by obstruction of the end. The ileum is dilated. Dr. Tuman, would you treat a partially obstructed patient medically? Do you have any luck with this sort of thing, or do you turn this right over to the surgeons?
Here again, the total clinical picture would have to be considered and evaluated, but if you're talking in terms of a degree of obstruction as indicated by dilated loops that are proximal to the narrowed area, this in itself is not necessarily an indication for operation. I think that a great deal would depend on what the patient's symptomatology might be and the state of his general health and how I could evaluate the activity of the process. The mere presence of some dilated loops I don't think calls for immediate surgery. These patients will sometimes settle down, compensate to some degree. Sometimes the inflammatory reaction will subside, either spontaneously or as a result of therapy. And I think that I would use other criteria rather than this alone.
Dr. Marshak, barium enema on this patient might result in no filling of the terminal ileum.
That's absolutely true. And you have to do a small bowel series on these patients to really evaluate the dilatation and the degree of stenosis.
And you don't mind giving barium to an obstructed patient? You've made that point already, I believe.
I do not mind giving barium, providing I have done a barium enema and there's no obstruction in the colon. The barium will come out eventually. It may take 6 to 8 days, but it'll come out.
I think this is very important. How do you prepare the colon in this patient? Do you give castor oil to a partially obstructed patient?
I will not use harsh laxatives in any patient with Crohn's disease. I try to stick to the mild laxatives and actually prepare them with enemas in the office. And I keep them on a liquid diet, and I give them a much milder laxative, and then I clean them out in the office. I don't give them harsh laxatives.
Would you name a mild laxative?
Yes.
Phenamint, maybe?
Yeah, milk of magnesia. I certainly wouldn't give them castor oil. In hot cases of Crohn's disease of the colon, I just don't do an enema at all. Just like ulcerative colitis, I stay away from that. You'll just make them sicker, and unless you really have to know what's going on, I won't do a barium enema on a hot case. You notice I don't say an acute case, on a hot case.
All right, the next thing for the surgeon to do, he's resecting this patient. Let's assume that the decision has been made to go right ahead, and he wants to know, he wants the pathologist to help him if possible, because he's not too familiar with this disease. He wants the pathologist to tell him where this disease should be resected. Dr. Hawk, what about a frozen section to assure the surgeon that he's not going to leave disease at the anastomosis? Would you comment on that?
Well, we have done frozen sections on this, and you can identify the normalcy of the histology in this dilated part of ileum, and you can also demonstrate clearly the disease process in the involved part. I think actually, as a matter of fact, the frozen section is corroborative, but experience now tells us that actually this gross assessment is just about as valid.
Dr. Gallagher, would you comment on knowing where to cut across here?
Well, let me be a little more specific. One, I would not do a frozen section. Two, I would not empirically go back 8, 12 inches or what have you. We know the recurrence rate is high. It doesn't make any difference if you do an extended resection. You're there to remove the disease and preserve as much bowel as you possibly can. And I would go back several centimeters with the gross demarcation. And even though the mucosa would be a little hyperemic at that point, I would certainly accept it, perhaps on the basis of stasis, dilatation, secondary to the obstruction. But I would not do an extended resection, and I wouldn't chase those lymph nodes.
You will leave all these lymph nodes right in the mesentery.
They're a reaction to the disease. They're not the cause.
All right, I think we can mark that again, we surgeons, because there is a tendency of some surgeons to talk about cutting out all of the mesentery with the nodes in it. And this may be all right, but we think it's unnecessary. I think the whole panel agrees, do they? Bill? Hawk?
Yeah,
Dr.
yes,
Hawk?
Yes. I agree totally with Dr. Gallagher. This is nothing but reactive lymphadenopathy. Even if there are granulomas in those lymph nodes, they're not going to do anything but just go away.
Now, Dr. Gallagher, do you mean that you might cut right through disease here and make an ileocolic anastomosis and get away with it, disease in the bowel?
If it's limited and minimal, yes. You have other alternatives here. You can transect, bring out that distal ileum. It's a mucus fistula, because if you're going to shave off pretty close, you're going to close diseased bowel and your stump may well blow out. You can then evaluate the situation and do an internal bypass or perform an ileostomy. I would be inclined to do an internal bypass.
And leave this disease in?
Now, which disease are we talking about?
This particular case here, would you do an ileotransverse colostomy or an exclusion operation and leave this disease and resect it at a later date, or would you like to do it now?
I would be tempted to do it as a definitive procedure. I would be inclined certainly to go ahead.
Mm-hmm.
Dr. Turnbull, why do you do an iliotransverse colostomy? Why don't you do an ilioascending colostomy if the colon is free of disease?
Well, you just said it. If it's free of disease, we find that 60% of the cecums and the area just above them are involved with the disease, and it may not look too bad. It may look pretty normal. And we don't leave much of the right colon at all. Now, I must find out what the panel does about this. Do they try to save a piece of colon? This is ascending colon here.
Well, suppose you were sure the ascending colon was free of disease. Would you use it?
I might use it if I could be sure about it, but I don't think it prevents diarrhea by saving 2 or 3 inches or so. But I'm not the one to say. Dr. Gallagher?
No, we save it. We save the ascending colon. There seems to be a tradition that if you have to mobilize the ileocolic area, that you end up doing an extended resection and going distal to the mid-transverse or proximal transverse colon, and it's not necessary. And again, the recurrence is going to be at the site of the anastomosis, and invariably it's going to be proximal to the anastomosis. And so why sacrifice needlessly that segment of colon?
All right, a good point. In other words, then, we're striking for conservatism and leaving all the intestine we can and making an anastomosis. We're leaving the mesentery alone. We're not frightened by large nodes. Any other comment on that?
Is an ilioascending colostomy so much more difficult an operation than an iliotransverse colostomy, Dr. Turnbull?
It really isn't, but one thing to consider is that the ascending colon has a tremendous diameter as compared to the terminal ileum, and the transverse colon doesn't. Mechanically, end to end may be a little easier, but that's an individual matter. Now we have an exclusion anastomosis. This is still being done. It's widely done. We always do this with intent, if we were going to do it, with intent to remove the disease. Now, Dr. Gallagher, back to you again. Is this satisfactory if you find this a tough situation in the operating room? Let's say it's complicated on the right side and you feel that you shouldn't take it out. We want to know whether this is a satisfactory way out.
It's a way out.
Suppose you encountered Crohn's disease localized to the terminal ileum and, let us say, maybe the cecum, all matted in, 14-year-old boy, the only son of a close friend of yours in college. A dark night, the parents are waiting out in the waiting room, and you don't have the first team on with you.
I'd transact and bypass with the intent of bringing the boy back for further surgery in the weeks ahead.
Okay, how long would you wait? Now, I didn't twist your arm.
Not less than 2 months.
Is this closed end here apt to blow out?
It certainly is.
But you feel you could wait under observation?
Well, the closure of a bypass or transaction like this is just as tricky as closing a duodenal stump. And I think some of the errors we fall into is that we know there's disease distal to it and a relative point of obstruction, so we set too many sutures and we turn in too big of a cuff and it necrotizes and it blows. A safer procedure here, of course, would create a mucus fistula with that distal segment.
Just bring that end out somewhere.
And you can create a mucus fistula just below the level of the skin, and it'll close over spontaneously in the majority of cases, and you're safe. And I think that as you bring this out, I would be inclined, if there's any doubt, to create a mucus fistula rather than to close a stump there.
These are wise words, and Dr. Marshak, this was an operation of choice at one time at Mount Sinai Hospital. I hope I'm ascribing this operation to the right place. Dr. Tooman, or Dr. Marshak first, you must have seen these patients through the years, not operated on later.
That's right, I did. And it was remarkable for a time how many of these got along very well without reoperation. And many papers were written from our hospital advocating this procedure without resecting this disease in the right lower quadrant, which was complicated by sinus tracts and fistulae, etc., and couldn't be removed. However, later on, these patients began to get in trouble. And we saw more and more of them until finally this is not done anymore, and the disease is gone after. Now, I would like to mention one complication that we're seeing more of, and that's carcinoma of the excluded loop. I have now seen 12 carcinomas of the excluded loop in cases such as this, and carcinoma of the small bowel is a rare disease. So I think it's wise in all these cases, if you can, to go back and take out the diseased loop.
Now, Dr. Tooman, your experience with this.
What I think about it has been well said by Dr. Gallagher and Dr. Marshak. I think this kind of an operation is a compromise that I would accept very reluctantly, only under conditions that made it necessary.
Just think, this operation was the operation of choice for many, many years. And here we are now saying, if you do this operation of choice, you should remove the disease later. Well, I think we've made all the points about
Dr.
that.
Turnbull, may I ask one question? In Dr. Spiro's recently published book, he advocates this exclusion type of operation, and I'm not sure, but I think he or someone else has made the statement that sometimes reanastomosis can be established, that this type of small bowel loop can be picked up again and used. And I just wonder whether anybody's ever seen that possible. I haven't.
Reanastomosis, Dr. Gallagher, your experience?
No, because when it's bypassed, it contracts down, strictures, it has a diameter of about the appendix. It's stiffened, corrugated, you can't turn in good ends. I think this is a hope and not a reality.
Now let's go on to some ways to hook up the bowel in Crohn's disease and criticize them or agree with them. Resection with end-to-end anastomosis in relatively surgically uncomplicated cases. Can I say, panel, that this is the best operation? I think the panel agrees then end-to-end anastomosis is the best. We have a problem with end-to-end anastomosis. We have a small ileum and a large colon, and this leads to all sorts of hookups, which we don't favor, and we offer the cheatal slit in the ileum to open it up to make it the size of the transverse colon to permit mechanically end-to-end anastomosis. Now, let's start again with Dr. Gallagher. Would you comment on this, or do you have a way out? Do you have another way to do this?
Well, I bevel and cut back on the endomesenteric surface, and then when I'm about halfway through the anastomosis, there's usually a little slippage of mucosa, and I'll trim that off on the small bowel side because it's relatively lost its blood supply. And I have never encountered a situation wherein I could not do an end-to-end anastomosis, and it's certainly to be favored without question.
End-to-end then is favored. Dr. Tooman, what's wrong with end to side?
Well, you're left with a blind loop, aside from the possibility that Dr. Marshak has already mentioned of carcinoma in the bypass segment, the possibility of bacterial overgrowth, bacterial competition, megaloblastic anemia, you might say an infected area there that doesn't drain. I think it's a very unphysiological way to do things.
Will this produce diarrhea in your experience?
Yes, it produces diarrhea. You have breakdown of bile salts. You have the destruction of B12 as a result of bacterial action in there. You have all the complications of blind loop and steatorrhea and destruction, as I said before, the bile salts. So I would be very much opposed to this.
Now, Don, you can always make end-to-end, right? Dr. Gallagher?
I feel that way.
Well, everyone can't always make end-to-end. You may see some big baggy colons here, 3 or 4 inches in diameter, and a very small ileum, and perhaps mechanically you may have a dangerous anastomosis if you force the issue to make end-to-end. Dr. Gallagher, could you concede that this might be a graceful way out if you couldn't make end-to-end?
Not a graceful way out. Now, another thing about this, when you do this, you've got 2 suture lines of vulnerability, too.
All right, true enough. I'd like to talk about side-to-side iliotransverse colostomy, or iliotransverse anastomosis, which is the commonest old-time operation done before exclusion operations were done. And to say something nasty about this, if I could, and have the panel do that. Bill, any reactions to this anastomosis? Let's say you open the abdomen, you're not equipped for one reason or another to take the disease out, so you make a side-to-side anastomosis between the ileum and colon, being done today in America very, very frequently by surgeons.
I philosophically don't like bypasses unless you intend to do something definitive to that later.
It doesn't really bypass anyway, does it?
No.
This an operation. Dr. Gallagher, comment on it.
No, you've just added more complications to their disease, and their state's going to deteriorate more rapidly after this operation, without any question, because now you've compounded the disease process, plus stasis, plus the bile salts, activity, bacterial breakdown, and what have you, and no one should do this operation. I don't think there's any question about that. Now, if one encounters a patient who's had this done, there is a trick that Dr. Matheson in our area has a great experience, and that is the patient who has had this procedure usually comes in with a weight of 80 pounds or less and is markedly debilitated. And if one can gain abdominal entry, simply transect, and they will recover uniformly well, have weight gain and what have you, and then later on you can do the definitive procedure. But there's a trick here. If you just transect this, you'll help the patient.
And what do you do with the 2 ends?
Again, this you have to play it at the time that you're there.
Now, Dr. Tooman, do you want to comment on this? I know you've seen many patients with this operation.
All I could say would be to make it unanimous. I think this is a very, very bad operation. I can't see much excuse for it.
Dr. Marshak, does this operation really bypass this disease? Would you comment on it?
No, it doesn't. This is like doing a gastroenterostomy when you have an obstruction of the ligament of Treitz. It's the exact same thing. What happens is that material is going to go into the right side of the colon, and it'll also go through the stoma. And finally, the right side of the colon will get bigger, and then the Crohn's disease will get strictured, and then it'll get bigger and bigger. And I have seen at least 3 blowouts in this type of anastomosis, and they're dangerous blowouts. 2 of these patients died.
On end colon to side ileum anastomosis, these are things we've all encountered. Dr. Tooman.
I think you're left with an unphysiological area of bowel, and you're going to have a certain amount of stasis there. You're going to have the various bacterial complications, the competition for B12, the bile salt breakdown. I don't think it's very good.
What do you think about side-to-side isoperistaltic iliotransverse colostomic anastomosis? Dr. Gallagher, this used to be a favorite at one time,
Well,
perhaps 20 years ago.
You have all these suture lines of vulnerability, and again, it's not a good operation.
Can somebody do it if he gets caught? Is it a way out?
It's a way out, no question about that. Again, it's not the best way out, though.
Dr. Marshak, you've seen plenty of these.
Plenty of these, and I'd like to point out one of the saving graces of what happens when you do this operation, why you don't see more complications of blind loops, etc., etc. The reason is that most of these patients get a recurrence at the anastomosis. This recurrence strictures down and prevents the formation of the blind loop in the small bowel. Now, it doesn't in the colon, but because of the recurrence, it prevents the formation of the blind loop in the small bowel, and that's what saves this particular patient. So the doctor thinks he has to deal with the recurrence, and he no longer has to worry about the fact that he did this poor operation.
All we've ever seen with these is trouble.
All right, the panel then likes end-to-end. Here is the commonest thing I hear on the telephone from surgeons or men doing surgery in the tri-state area in our part of the country, a massive set of fiddle string adhesions obstructing the terminal ileum and any dilated ileum. You take him in the operating room and you encounter a massive adhesive band consisting of fiddle string type of adhesions. Dr. Hawk, what should the surgeon do? I'm going to ask you this. I think you're involved.
The thing that one is going to be very suspicious about is that there may be some interesting fissures or fistulae which connect this dilated terminal ileum to that cecum. And if one starts dissecting it, it may not be long before one has opened up some interesting fistulous tracts and then really is in a great deal of difficulty.
The commonest thing I hear is that the surgeon says, I freed up the adhesions to take care of the obstruction. And 10 or 11 days later, there was a high fever, and it was seen that an abdominal mass was developing, and finally a fecal fistula through the laparotomy incision. What is there about adhesions, Dr. Hawk, in Crohn's disease that makes us believe that we shouldn't cut them?
These adhesions are over the terminations of some of these interesting little structures known as fissures. And these fissures are rose thorns that extend out through the bowel wall. This is all the way through the muscularis propria, and there it terminates in an abscess. And one loop of gut is adherent to another, oftentimes at the point of this abscess, which then is free to burrow through the wall of the adherent loop and produce a fistulous tract. It's quite easy to see that if you tear the adhesion away from the termination of this abscess, then you have free communication to the peritoneal cavity, and you can get interesting fecal fistulas just on this mechanism alone.
Dr. Gallagher, you've encountered this many times. Do you intend to resect it if you can, or is there something less you can do?
Well, if you're there, you'd better be prepared, and under usual circumstances, I would resect.
I would like to give an example where this might be dangerous. Suppose you patient had symptoms in the right urinary tract. You did an IVP, the right ureter is dilated, and this dilatation is due to the so-called, I could use a better term, but retroperitoneal fibrosis secondary to the inflammatory reaction that you have in the terminal ileum, and it's precisely due to the mechanism that Dr. Hawk and Dr. Turnbull just described. Now, in this type of case, in order to free this ureter, this disease process has to die down. Now, would you take out the ileum in these cases, or would you bypass it and then go back later and take it out?
Well, in the circumstances you've described, I'd bypass. But nobody's told me about any dilated ureter just now.
I thought I would bring it in because nobody mentioned the fact that this happens sometimes in Crohn's disease, and it happens precisely because of the fibrosis that Dr. Turnbull just described overlying these fissures. And this is not that uncommon. And I'm sure with your extensive experience, you must have run into such a case, Dr. Gallagher.
And I have gone in and I have resected, and I wished I hadn't, because all hell breaks loose. There's no question about that.
There are the wise words. Thank you. Henry?
Yeah, I was just going to ask whether they do an IV pyelogram on these patients. We've done this and sometimes been very glad that we had.
I think that all surgeons, unless it's an emergency, do an IV pyelogram. Dr. Marshak?
I think that any patient with Crohn's disease who have any urinary symptoms, that you should do an IV pyelogram to make sure that this mass isn't blocking the ureter.
Could I sum up briefly, and if the panel doesn't agree, say something? If you open the abdomen and you run into Crohn's disease and you don't intend to take it out, just leave it alone and bypass it or do something, but leave the disease itself alone with full intent to resect it later when the disease has subsided. Would the panel buy that? Don't cut adhesions and so forth. Now, we're just about through. We're running out of time, but we have time for one or two more. The ileum involves the sigmoid colon, remarkably so. What do you do with this patient, Dr. Gallagher?
To undergo a massive resection here, I think, is fraught with difficulty. And here's one for transection and bypass. Now, what you do with the ends, again, depends upon the situation at surgery and how you view things.
Dr. Tooman, do you have any thoughts in this regard? This is a real problem and a constant problem in this disease.
Very tough one. I think I would ask the surgeon to play it the way Dr. Gallagher's recommended.
Well, one would have to gamble that the sigmoid segment would respond after it's been bypassed, and I don't know how you can tell this.
Well, in this situation, from the Röntgen point of view, I'd like to point out something, that the disease in the sigmoid is not really Crohn's disease. It's like the lymph nodes. I think that you can resect the small bowel here, and then you can close the hole in the sigmoid and get away with it.
Oh, no. Man, that's so indurated and brawny and sitting in a bed of injured tissue, you can expect that sigmoid repair to blow.
Well, it's not always that brawny. It depends on whether or not it's adherent or whether there's a fistula there of degree.
Just a few minutes ago, we all decided we wouldn't touch all those adhesions, those violin strings and everything else.
Right.
Because of, so why do you want to mess around with this?
This is our point, that if you mess around with it, you may be brewing some trouble because you have little holes. Dr. Marshak?
I didn't say to take away the adhesions. I said to make a wide opening into that sigmoid and then to attempt to close it. This is feasible if you make the opening wide enough and long enough. If you don't like to do it, fine. I want to assure this audience I never tried it myself.
We're not recommending that the sigmoid be resected. It may not have to be even touched, given a bypass here and exteriorization of this.
Can we resect the right and left side together, Dr. Gallagher?
Oh, yes, and you can go home with a feeling of great achievement, but it's risky.
We're out of time, I'm very sorry to say, because we're really not half through. I want to thank the panel for their expertise.
And we'd like to add our thanks, too, to the speakers and to the Board of Regents of the American College of Surgeons for their cooperation in recording and disseminating this material. You'll have a front row seat for all of the clinically valuable panel discussions, special lectures, and symposia we've taped in Atlantic City during the coming weeks on Audio Digest Surgery, produced and copyrighted twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.